Hello everyone, I'm Renee Mehrra and welcome to Your Health Matters, our innovative health series with experts providing their deep insights into critical public health issues so we can maintain good health. Today I'm at the Mount Sinai Health System, which is the oldest and one of the largest and most prestigious healthcare systems in the United States. And we're talking to our guest on a very critical public health issue. It's bladder cancer. Every year in the US, over 70,000 cases are diagnosed with bladder cancer. So it is important to catch it when it's in the early detection stages. Joining me today from Mount Sinai Health System, we have a whole great team of doctors. Dr. Peter Wicklund, Director of the Bladder Cancer Program. Dr. Renee Mehrra, Assistant Professor of Urology. Dr. John Spakianis, Assistant Professor of Urology. And Dr. Matthew Galsky, Professor of Hematology and Oncology. Thank you so much, gentlemen, for sharing with us your deep insights today on bladder cancer. And I'm going to talk to you, Dr. Wicklund, first. At its basic, why is bladder an important part of the human body?
Well, the bladder is important. There's basically only two ways how you get rid of toxic substances from the human body.
Right.
And one is through the intestine and the other is through the urine. So urine is a very important sort of end product and has to come out. And
Right.
if you have a blockage in the urine flow, you will become uremic and you cannot live many days if you block urine flow. So urine has to come out. And the bladder is basically a way to store urine. And the reflex, how the bladder is working, is also complex. Is controlled by the spinal cord and
Right.
the brain, several centers in the brain. So it's more complicated than you think.
Wow.
Because it's supposed to be able to store urine and to let it out at a certain time when it's socially acceptable. And also it's important because otherwise you don't want to have incontinence, for instance, because
Right.
that's a problem. And in general, one of the basic functions in the body is controlled by the urinary bladder.
So there's a lot of cellular intelligence going on over here.
Yeah, especially the neuronal and muscle network talking together with each other. And that is a
Wow.
complex thing. Yes.
Interesting. I know that generally when cells grow uncontrollably, you get urothelial carcinoma, but who gets bladder cancer?
Bladder cancer is really a cancer of an exposure to a chemical, and the most common chemical of exposure for patients is tobacco. So
I see.
patients who smoke cigarettes are more likelihood to develop bladder cancer. There are some other chemicals that we know of, diesel fumes as well, aniline dyes that used to be very popular in the factories, as well as dyes from paints. So patients or people who used to work in the factories making the paints also can develop those chemicals. And like Dr. Wicklund said, it's really all about breathing in
Right.
those chemicals and then having to get rid of the toxins in the urine. Wow. And as those chemicals are sitting in the bladder, it causes a damage to cause a bladder cancer.
So all this inhaling of toxins can be hazardous to your health. So what are the two main types of bladder cancer tumors?
The bladder's a round, thick-walled structure, kind of like a cantaloupe has a thick wall. And cancer can develop typically on the inside wall, and sometimes that cancer stays there for a little while, and that's called superficial bladder cancer, or now it's called non-muscle invasive bladder cancer. Or that cancer can invade deeper into the wall of the bladder, and that's typically called muscle invasive bladder cancer. These two types of bladder cancers differ in terms of how they initially present, the symptoms that occur initially. They differ in terms of the prognosis, and they differ very much in terms of the treatment. So when bladder cancer is diagnosed, that's one of the first distinctions that we make, how far the cancer has invaded into that wall.
So what are the symptoms that we're looking at?
The most common symptom is blood in the urine, and typically that's blood that can be seen. That blood doesn't have to be present all the time. Sometimes it comes and goes, but that's typically the most common presenting sign of bladder cancer.
And even stinging, burning urine is...
That can be as well.
Can be or may not be.
Now, blood in the urine, a little bit more related to cancer, changes in urinary flow, burning, urinary frequency. These are relatively non-specific symptoms, can be related to many different things, but any symptoms like that should certainly prompt a visit to a doctor.
So because women have UTI infections and that's burning and stinging.
That's correct.
But that has nothing to do with bladder cancer.
That's correct.
I see.
But it can.
But the bladder is a relatively unintelligent organ. So almost anything that sort of irritants for the bladder will cause the same symptom.
Normally when they present with hematuria or blood in the urine, they get referred to urologists. And we start with a CAT scan, usually with CT of the abdomen and pelvis. And we do cystoscopy, which is basically colonoscopy, except we run the camera within the urinary bladder to assess the entire bladder. And if there's any lesions or any abnormal changes within the bladder, we biopsy it. And that's how we basically diagnose.
So how do you get the camera into the bladder?
Well, we start, it's an office procedure. It's
So that's how you're diagnosing
yes.
it? Okay.
And it normally can take, a couple of minutes in the office under just local anesthesia or just some numbing medicine that we put in the urethra, which is a lining within the phallus or penis, or that just numbs them up for a couple of minutes. It's long enough that we can just run the camera inside and assess the bladder.
Tell us how the robotic surgery works and why is it so effective?
The first case for bladder cancer I did 2003, and at that time most surgeons were not really aware that there were robots. But the robot is very helpful in several ways. One of the most important and most impressive things with the robot is that you have a great magnification. So you see things in much larger than they actually are. Then you can do minimal invasive surgery, which means that you don't have to open the patients. And if you don't open the patients, the recovery of the patients will be much quicker. So that was one of the most sort of impressive things when we started to do this operation, that the patient could get out of bed the day after surgery and they go home much quicker and so on. The robot also helps you to move, because you can do this with normal keyhole surgery, but they are long, rigid sticks and actually very difficult to do. The robot helps you because you have articulated wrists on the robot and you can do much more complex things but still see.
It's very precise.
Yes, exactly.
Dr. Mehrra, can you share your thoughts? Why is robotic surgery so effective?
So robotic surgery or minimal invasive surgery, the benefit comes from the precision. So we have many studies that show that the blood loss is certainly less compared to when you do it the traditional open approach. As a result of having only small incisions, the pain management after the surgery is significantly easier for the physician, and patients start to ambulate or start walking around sooner than the traditional open incision that we give them. And also when, in men, when you do a cystectomy or remove the bladder, the prostate also comes out with it. So this allows us to perhaps get closer to the neurovascular bundles or the nerves that they assist with erectile function, that allows us better to preserve these nerves robotically.
I see.
So the precision is definitely key here.
We'll take a quick break, and when we come back, we'll be talking to our guests about the new chemotherapy treatments. Stay with us. Welcome back to Your Health Matters, where we're here at Mount Sinai in Manhattan. And Dr. Wiklund, I know that you've been performing a lot of robotic surgery for bladder cancer, almost over 3,000? That's a lot.
Well, that's, since we started very early, then it tends to be a lot of operations. And it's very important to practice. So if you want to become a good surgeon, you have to do many cases. It's not just for robotic surgery, for every type of surgical procedure, basically.
But is it a complicated surgery?
We are discussing different types of bladder cancer. If you think about the bladder cancer that's growing into the wall of the bladder, you actually have to remove the bladder and the prostate and all the lymph nodes, and you have to make a urinary diversion. Right. Because urine has to come out.
So what does a urinary diversion mean?
Yes, so
urine
have to come out, basically. Yeah. And it can, there are three different types of diversions. So the more simpler thing to do is to connect it to a conduit. So you have a stoma, so urine forms in a bag outside.
I see.
The other possibilities is to make new bladders on the inside. One is called a neo bladder, and it's actually performed in the same place as the old bladder.
I see.
And then you empty yourself through the urethra. So it's not normal voiding, but you urinate through the urethra. And then there is another one where you make it a bladder, but you have to empty it with a catheter on the outside. So there are three.
Is that painful?
No, it isn't.
Thank God.
If it works correctly, it's not painful.
I see. Neoadjuvant therapy, what is that all about?
When bladder cancer has invaded into the muscle layer of the bladder, removal of the bladder, as we've heard, is the mainstay of treatment. But unfortunately, even with that operation, we know that a subset of patients, months to years later, will have the cancer show up somewhere else in the body. And that's because microscopic cancer cells broke off from the initial cancer and spread through the bloodstream or the lymphatic system even before the surgery took place. Those cells are too small to be seen, so we can't detect them prior to surgery. Because those cells might be present, we give chemotherapy before surgery to try and kill those cells in order to increase the curability of muscle-invasive bladder cancer, and that's what neoadjuvant chemotherapy is.
I see. And how successful is it?
Neoadjuvant chemotherapy increases the likelihood of cure with surgery compared to surgery alone. However, it's not for everyone,
Right.
and there's a discussion that needs to take place about the risks versus the benefits of treatment, and we make that decision on a very individualized basis.
So who qualifies for neoadjuvant therapy as opposed to those who need surgery?
Anyone who has bladder cancer that's invaded into the muscle layer, we have a discussion about neoadjuvant chemotherapy, and then there are factors related to the cancer itself and factors related to the patient that might make that a better strategy or a worse strategy.
I see. Now, immunotherapy, I believe, is one of the new developments in chemotherapy.
Immunotherapy is a type of treatment that we can give patients who have advanced bladder cancer, who basically the treatment, what it does, it helps unmask the actual tumor, so your own immune system, your own cells, your own immune cells can actually go forward and attack and kill the cancer. Because cancers are actually our own normal cells that grow out of control, like you had previously mentioned, they are sometimes masked and the immune system cannot see them. And so these types of therapies unmask the cancer and have an attack.
I see. Why do you feel treating patients for bladder cancer is multimodal?
Well, I think these are very complex cancers in terms of, like we just discussed, we treat them both with surgery and chemotherapy and immunotherapy. They are complicated because of the need to have a urinary diversion, and so a team approach is very important. The team includes specialists like ourselves here, but as well as our anesthesia colleagues, physical therapists, nutritionists, social workers. It's just, and especially here at Mount Sinai, we've put together a vast team of experts to be able to give the best care to the patients, which is extremely important for their treatment and their recovery and their longevity for beating this cancer.
What are some of the pre and post-surgery things that a patient should be looking at?
When, let's say, we decide to proceed with surgery, they need to decide what kind of diversion is recommended and what they decide on.
Yeah.
And as Professor Wickland alluded to, some patients go for the ileal conduit, which is a stoma that has a bag. So they need to meet with the ostomy nurse who basically gets them familiar with the process and how to change it, how to take care of it after the surgery, and where it goes in terms of the location on the abdomen. So once that's basically in the pre-op setting. Also, we have a meet with our anesthesiology colleagues who discuss with them in terms of what to do the day before the operation, how to get prepared for the anesthesia. And after the surgery, it's again multidisciplinary approach in terms of getting them through the recovery. And usually the first 30 days is critical. We have our nutritionists on board. We have our ostomy nursing staff who saw them before the surgery to continue to follow them. And we try to minimize the use of narcotics to help with the return of bowel function. And that's one of the things we have established here in our department, that basically we have minimal to none use of narcotics for pain management after the surgery. And post-op, after the surgery, again, they follow up with urologists and oncologists for future scans and so forth.
In terms of diet, what should they be eating, after post-surgery or even pre?
Typically, we always advise the patient to be on a healthy diet, but for these patients, we want them to be on high-calorie diets.
Okay.
A lot of their body is going through a lot of process, and they need basically a lot of fuel to get through this. So we try to get them through diets that have a lot of energy sources.
I see. And of course, no smoking, no drinking.
Of course. I think that falls into before the surgery consultation.
And the follow-up time, after surgery, when they should be coming back to the doctor?
Typically, we see them within 2 weeks of surgery. Afterwards, depending on the stage of the cancer and the lymph node involvement or whether the cancer was outside the bladder, we decide if they did not get systemic therapy or chemotherapy, they return back to medical oncologists to see what their options are. And afterwards, CT scans is typically performed every 3 to 6 months for first 3-4 years at least.
I see. Dr. Wiklund, does it mean that all bladders have to be removed if cancerous?
Up until now, we have focused on the more aggressive tumors. Most bladder cancers, 2/3, will not have to be removed because they only have
That's
the
good news.
superficial cancer that can be controlled from the inside. You just do a cystoscopy and you can maybe burn a little bit on the tumor, but you definitely do not need to take the bladder out in most patients.
I see. Well, we all know that Mount Sinai Health System is very acclaimed for being ahead of the curve in research and having excellence in clinical care. So when we come back, we're going to be talking to our guests on the new research in bladder cancer. Stay with us. We're back and we're talking to our guests from Mount Sinai, and we talked about earlier that Mount Sinai is ahead in cutting-edge research, and we're going to be talking to our guests about what's new in bladder cancer research. Tell us, does genomics play a very big role in this?
Sure, Renee. Genomics plays a role in this. There is a small genetic component, meaning that there are some family type diseases that run in the family that can develop bladder cancer. It's a small population, but the genetics of the cancer is very important. And one thing that we've been able to do here at Mount Sinai with all our bladder cancer patients, and like Peter said, whether they're superficial or non-invasive or invasive, we're able to take the patient's tumors, their urine and their blood, with the consent, of course, and then be able to run a variety of different genetic and immune tests and analyze these tumors, which help us understand the disease process a little bit more, but also helps our medical colleagues and ourselves be able to direct the type of treatment that we can use. And this goes back to how important it is to have this whole team approach to treating patients with bladder cancer. So we've been able to do this with over 200 patients now, and we've learned a tremendous amount about the cancers, which has led us to a variety of different clinical trials that maybe Dr. Galsky can comment on.
So we're doing a number of clinical trials across the whole spectrum of disease states of bladder cancer. What I mean is both superficial bladder cancer and invasive bladder cancer, and even when bladder cancer has spread. And these clinical trials are testing new approaches, mostly involving immunotherapy, mostly trying to train the body's immune system to attack the cancer.
What role does oncology play, since you're an oncologist?
An oncologist uses medicine to treat cancer, and that medicine could be administered in a variety of ways. It could be pills, it could be administered intravenously, but that's really our main strategy to treat cancer. And because there are a variety of ways to treat cancer, surgery, radiation, using medicines, that's why this really does require a team approach.
And since you're doing clinical trials, you work as a team, and that is important because when somebody comes and is diagnosed with bladder cancer, we have a whole team that has amazing skill set and is able to work. We talked about that's being multimodal, and so working together, helps in bringing a lot of relief and benefits to to everybody.
Absolutely. I think this is the most important part of the bladder cancer treatment, is to have a team, because as we have discussed before, it starts long before the actual surgery. So it's a combination of what you do before the operation. So it has a team with physiotherapists, ostoma nurse, you have the medical oncologist to give neoadjuvant chemotherapy, you actually do the operation, and then it has to do with the rehabilitation of the patient and the follow-up schedule after, and even immunotherapy or more chemotherapy and so on. So definitely it's a team effort.
Right. And I think the follow-up is very critical in this situation, because if you don't have the proper follow-ups, can it come back? Can bladder cancer?
Yes, it can. I tell all my patients that I'm going to follow you until you move away or I retire, basically. So you're the bladder cancer patient. First, you follow them for the tumor issue. So you have to follow them for maybe 5 years if they have a muscle-invasive tumor. If they have a superficial tumor, it may come back. So you follow them with cystoscopy. And if they have a urinary diversion, which we nowadays make out of intestine, maybe this will be different in the future, but still it's an intestinal new bladder or diversion. So then you must check that part also.
And can it metastasize?
Bladder cancer can metastasize, and usually the risk for that happening is most within the first several years after diagnosis of muscle-invasive bladder cancer, and that's why we follow patients so closely during that period of time.
I see. What do you see in the next 10, 15 years in bladder cancer research?
Yes, I see great chances of progress, because we are already now developing new types of treatment, especially immune therapies that are coming out. We are developing the robotic surgery, so making it less invasive so that the patient becomes much more mobile and stays very few days in the hospital, can keep the function as before surgery more and more. So that is moving ahead all the time. And also I think that there will be more personalized medicine, which means that you can actually take out the specific tumor from this patient, test it, which are the cytostatic agents that you want to use for this specific patient. So I think that will be more the personalization of medicine. I don't know if you...
I'll give you an example, and you're talking about time horizons of 10 to 20 years, and I'll tell you about something that we're doing right now. Right now we have a clinical trial where when a bladder tumor is removed, we can sequence the tumor genomically, identify which of the genes in that tumor might be most apparent to an individual patient's immune system, make a vaccine specifically for that patient, and then give them that vaccine in an attempt to prevent their bladder cancer from coming back. So that's the reality today. And when you think that's the reality today, what we might be doing in 10 to 20 years is mind-boggling.
Right. So you talked about vaccines, and that's again personalized?
That's correct.
And Renee, what I like to also add is that while the genetics and all this great clinical trials and research we're doing and learning about the tumors, we have a whole other level of research, which is basically looking at the patient data, the outcomes of the surgeries, the patient's demographics, and that one thing that's actually come out of this with our research group that we have is when we looked at this data, we saw that our patients were taking a lot of opioids for pain control. And so by combining the robotic surgery and combining a special protocol with our anesthesiologist, what we've been able to do, as Dr. Mehrra has mentioned, is give zero narcotics, no opioids to our patients from the beginning to the end, which that alone has actually decreased our complication rates a significant amount. And so while the genetics are important, also looking at our patients, looking at our outcomes from our procedures are also very important to drive the next 10 to 20 years.
And I think it's so gratifying to hear the success stories of patients, when they get better and they come to you and they say, wow, I'm just feeling a lot better, and without all those pain medications. Yeah. Your final thoughts, Dr. Mehrra?
Again, I think it's a disease that has to be done in a major academic center where the volume is high, and we have a team that is driven just to drive the care for these patients.
I think what we're coming out here with is, of course, the biggest takeaway in bladder cancer is if you see blood in your urine, please see your urologist right away. Second, do not smoke, because that really is pretty much for every chronic illness or any illness and for any cancer. It's not good for you. And third, most important thing is stay away as much as you can from chemicals because they can be very hazardous to your health and for bladder cancer. Thank you so much. Our guests from our Mount Sinai team talking about bladder cancer and why is it so important for early detection and prevention. And that's what Your Health Matters is all about. So stay healthy, stay positive. I'm Renee Mehrra.